Welcome back, everyone. We now have a presentation on Health Insurance 101 from the Office of the Commissioner of Insurance. We have Sharon and Shelley with us today. Sharon is a health insurance attorney with the Office of the Commissioner of Insurance. And before working at OCI, she was a healthcare finance analyst for the Massachusetts State Legislature, a clinic manager, and a manager of a pharmaceutical clinical trial. Sharon lives in Milwaukee with her twin babies and twin cats. Shelley is a health insurance examiner for the Office of the Commissioner of Insurance. She has been with OCI for 6 years and in the insurance industry for 30 years. Prior to coming to OCI, she was a property and casualty underwriter for QBE Insurance. I will go ahead and hand it over to Sharon and Shelley for our presentation.
Good morning. As Elizabeth said, my name is Shelley. I am with the OCI here in Madison. Just want to thank everybody for coming aboard today and listening to our presentation. So let's do next slide, please. OCI's mission has both a consumer component and a company component. In addition to helping consumers navigate the insurance marketplace, we also ensure companies are healthy from a financial perspective in terms of having reliable, compliant business practices. This helps to ensure that Wisconsin consumers continue to have plenty of dependable choices. Next slide, please. The first sighting of health insurance was approximately in 1929 when large industrial employers created access to health insurance for their employees. Next, between the 1950s and the 1960s, labor unions and more individuals began seeking health insurance, typically creating a safety net for catastrophic health conditions. In 1965, the passage of Medicare and Medicaid resulted in one basic program of health insurance for persons aged 65 and older, and another program providing health insurance for people with limited income funded by state and federal sources, respectively. And then lastly, beginning in the 1970s, the concept of managed care through health maintenance organizations began. Next slide, please. The principles of health insurance are risk and pooling. Risk in insurance is the uncertainty of a financial loss. Risk tolerance is the amount of risk one is willing or wanting to take on by themselves or can afford to take on for themselves. Insurance is defined as a transference of risk. One pays the insurance company to take the financial risk from you for a fee called a premium. Typically, the more risk you transfer to an insurer, the higher that premium is for the product, as the potential for claims then exist. When applied to healthcare, the risk being transferred is the need for medical care during the year. The amount of coverage someone is willing to pay, the amount of coverage someone is willing to pay for through premiums may be affected not only by the general risk, but also specific or anticipated risks, such as needing a knee replacement or planning to start a family. Often, you will see lower premiums with group products. The reason for this is the law of large numbers, or pooling of risks. Next slide, please. This is the insurance definition of the category in which health insurance falls within. The global classification of disability encompasses the list shown on the screen. These go beyond typical health insurance and cover for the most part, the five pieces that you'll see on this slide. Next slide, please. Insurance law follows the state for which a policy was purchased in. An exception, though, for example, is when an employer is located, let's say, in the state of Missouri, but has employees here in Wisconsin. There can be times where Wisconsin OCI would have jurisdiction over that health insurance plan for those located here. There would need to be at least 25% of the total number of employees residing in Wisconsin in order for us to have that jurisdiction. Most disability policies offer a wide range of coverages and limits. The Commissioner has the authority to regulate the terms of insurance contracts to protect the policyholder. The insurance laws establish statutory standards that are clear enough to protect the insureds and to give the Commissioner authority to set specific standards and provisions through rulemaking powers. A group insurance policy is defined as a health benefit plan that is issued by an insurer to or through an employer on behalf of a group consisting of at least two employees of that group, including at least two eligible employees. Under ERISA, which is the Federal Employee Retirement Income Security Act of 1974, a group insurance plan is defined as an employee welfare plan to the extent that the employee welfare plan provides medical care, including items and services paid for as medical care, to their employees or to their dependents, as defined under the terms of the employee welfare plan, directly or through insurance, reimbursement, or otherwise. And lastly, a defined network plan is defined as a health benefit plan that requires an enrollee of that plan to use providers that are managed, owned, under contract with, or employed by the insurer offering the health benefit plan. Next slide, please. A healthcare plan means an insurance contract providing coverage for health insurance expenses. A comprehensive health insurance policy offers extensive coverage and acts as a financial pillow in case of medical emergencies. Unlike basic health insurance plans, a comprehensive policy covers outpatient as well as inpatient treatments, including consultations, medical tests, as well as hospital stays. Disease specific policies provide coverage and benefits only for the specified causes of sickness, disease, or injury, such as heart attack or stroke, and often coverage is limited in amounts or limited in the amount of time coverage is provided. Next slide, please. The larger the group pooled together, the greater ability to spread the risk. An insurer can spread its risk for high claims by collecting premium from more people, which then reduces the insurer's risks and typically lowers the premium. Health insurance provided to employees by an employer is called a group coverage, but health insurance you purchase on your own is called individual coverage. A small employer means, with respect to a calendar year and a plan year, an employer that employed an average of at least two, but not more than 50 employee on business days during the preceding calendar year. The Small Business Health Options Program, or SHOP, marketplace plans help small businesses provide health coverage to their employees and is open to employers with 50 or fewer full-time employees. A large employer means, in connection with a group health plan, with respect to a calendar year and a plan year, an employer who has employed an average of at least 51 employees on business days during that preceding calendar year. The 80-20 part of health insurance refers to coinsurance. Your health insurance pays 80% of the total cost of the bill, and you would pay 20% of your total healthcare costs until you reach your maximum out-of-pocket limit. Managed care plans are a type of health insurance. They have contracts with healthcare providers and medical facilities to provide care for members at reduced costs. These providers make up the plan's network. For example, a health maintenance organization, or an HMO, usually only pays for care within their network. Some examples of federal programs are Medicare or Medicaid, and some state programs, for example, are Badger Care, Care for Kids, and Forward Health. Next slide, please. A managed care plan is defined as any health benefit plan that requires or creates incentives for an enrollee to use providers that are owned, managed, or under contract with the insurer offering that health benefit plan. Wisconsin statutes define three types of managed care plans. They are health maintenance organizations, or HMOs, preferred provider plans, or PPOs, and limited service health organizations. Next slide, please. So, simply put, when a consumer selects a plan with less choices for a network, the premium will be lower versus selecting a plan with more choices, which in turn then means more premium. Next slide, please. HMOs offer predictable cost sharing and administrative simplicity for patients. These features come with fairly restrictive rules about which providers a patient may see. LSHOs often have a limited range of services performed by providers selected by that organization. A PPP or PPO plan provide more flexibility when picking a doctor or hospital. They also feature a network of providers, but there are fewer restrictions on seeing non-network providers. In addition, your PPO insurance will pay if you see a non-network provider, although it may be at a lower rate. A point of service plan is generally like an HMO. It requires the policyholder to choose an in network primary care doctor and to get referrals then from that doctor if they want the policy to cover a specialist services that would be out of network. Next slide, please. This particular slide is a purely descriptive slide that shows again when a consumer chooses a plan with less choices for the network, the premium will be lower versus choosing a plan with more choices, which in turn will mean then more premium. Next slide, please. Another way insurers protect against risk is to narrow the coverage options they offer. This time through a specific type of treatment or care they will cover rather than coverage at the provider level. The ones listed on this slide are some of the examples we see of those types of plans. Next slide, please. Qualified health plans are comprehensive ACA, Affordable Care Act, compliant plans offered on and off the federal exchange. Medicare Supplement and Select policies provide coverage for some of the costs not covered by Medicare Part A and Medicare Part B. Long term care in general refers to a broad range of services you may need for an extended period of time because of a chronic illness or disability. Long term care includes medical services such as nursing home or therapies. It also includes supportive services for the activities of daily living, such as help in bathing, dressing, getting in and out of bed, taking medications, or preparing meals. Care can be in a Care can be provided in a variety of settings, including nursing home, their home, an adult daycare center, or a group living arrangement with supportive services. We'll touch on short term policies here in a minute. Next slide, please. Self funded ERISA plans are typically large employers that are governed primarily by the United States Department of Labor. Labor union and employee welfare plans are also governed by the United States Department of Labor. Discount plans provide discounts on medical procedures with certain doctors or medical related costs, such as prescriptions, just like using a coupon at a store. These plans are not health insurance plans, though, in the traditional sense. Medicare Advantage plans are the federal government's version of a Medicare EPO, and it replaces Part A and Part B. The federal government and Centers for Medicare and Medicaid Services directly contract with insurers to provide the Medicare benefits. Medicare Part D is the prescription drug plan that is sold separately from Medicare supplement insurance or traditional A or B, outpatient coverage that is offered by the federal government. Healthcare Sharing Ministries was one of the original versions of a GoFundMe, and members share a common belief and provide funds to each other for medical expenses. Direct primary care is reemerging from the past, with providers, typically primary care internists or family practitioners, negotiating directly with consumers. Next slide, please. So, here are some of the characteristics of a short term limited duration plan. They are not required to include specific ACA consumer protections. Some consumers may believe that ACA compliant plans offer and are priced to include unwanted benefits. So, for them, short term plans may offer premiums that are lower than unsubsidized premiums for the ACA compliant policies, but then they also expose enrolled members to additional healthcare costs in the form of higher cost sharing and non covered services. Price sensitive consumers lacking full information about ACA subsidies may gravitate towards enrolling in these lower premium plans despite their limited coverage protections and high out of pocket costs. In many cases, short term plans may not be the lowest cost option. For the many consumers eligible for the federal premium tax credits and cost sharing subsidies, ACA compliant plan premiums will be lower or comparable to these plans and offer additional benefits and potentially less cost sharing. As stated, the loss of a short term plan does not trigger a special enrollment period back onto the marketplace. These policies often are sold as a benefit to an out of state association plan, and there are times when we may or may not have jurisdiction over them here at OCI. If OCI finds that an insurer or agent represents a short term plan as compliant with the ACA or as providing more than a bridge coverage, is engaging in unfair marketing practices, and we will take enforcement action. Next slide, please. Insurers selling these plans must include in their marketing materials a consumer disclosure notice as prescribed by the Federal Department of Health and Human Services. This disclosure says that coverage is not required to comply with certain federal market requirements for health insurance, principally those contained in the Affordable Care Act. Be sure to check your policy carefully to make sure you are aware of any exclusions or limitations regarding coverage of pre-existing conditions or health benefits. The policy might also have a lifetime and or annual dollar limit on health benefits. And it also must state if this coverage expires or you lose eligibility for this coverage, you might have to wait until open enrollment period to get other health insurance coverage. Next slide, please. Unlike ACA regulated comprehensive coverage, short term plans may limit coverage based on an individual's prior health status or a pre existing condition. They may limit maximum annual and lifetime dollar coverage and lack guaranteed renewability. Many plans also state that conditions that develop under the prior plan with them will be considered pre existing. They can and will conduct post claims underwriting, which is where an insurer can review the consumer's medical history, determine that there was a prior diagnosis or treatment, and use that as a basis to deny a claim. Next slide, please. By definition, healthcare sharing ministries are not insurance. There are over 100 healthcare sharing ministries certified by the Federal Department of Health and Human Services as meeting the minimum requirement to meet the individual mandate under the ACA. The member is required to pay any medical bill first, with certain health needs eligible to be posted in a newsletter for other members to donate funds then to offset that individual's expense. These were examples of the original GoFundMe types of accounts. Next slide, please. Some of the characteristics of these healthcare sharing ministries are they are non insurance entities, which means they share a common set of ethical or religious beliefs and share medical expenses among members in accordance with those beliefs. In a healthcare sharing ministry, members contribute, typically on a monthly basis, a payment or share to cover the qualifying medical expenses of other members. Then that ministry will either match paying members with the who match paying members with those who need those funds for healthcare costs, or pool all the money shares and administer payments to those members directly. Next slide, please. Some of the limitations of healthcare sharing ministries is that they are not required to comply with the ACA's consumer protections, offer coverage for pre-existing conditions, usually may or may not be excluded. Medical benefits are typically far more limited than ACA compliant plans, and members are never guaranteed payment, even for covered services. They cap out of pocket costs and are not required to cover essential health benefits. They can set monthly, annual, and lifetime limits stated as caps on those coverages. And lastly, they may charge a higher rate based on health status, and some will deny membership to those who can't even pass a medical screen. Next slide, please. Some of the federal programs that are out there are the following. Medicare is a broad program of health insurance designed to assist the nation's elderly to meet hospital, medical, and other health costs. Medicare is typically available to most individuals 65 years and older. The Employee Retirement Income Security Act of 1974, or ERISA, is a federal law that sets minimum standards for most voluntarily established retirement and health plans in private industry to provide protections for those in those plans. The Consolidated Omnibus Budget Reconciliation Act, or COBRA, gives workers and their families who lose their health benefits the right to choose to continue health benefits provided by that group plan for a limited period of time under circumstances such as voluntary or involuntary job loss, reduction in the hours worked, transition between jobs, a death, a divorce, or other life qualifying events. Qualified individuals may be required to pay the entire premium for coverage. The Mother's Health Protection Act, or Newborns Act, includes important protections for mothers and their newborn children regarding the length of a hospital stay following childbirth. This requires group health plans that offer maternity coverage to pay for at least a 48-hour hospital stay following childbirth or 96 hours in the case of a C-section. The Women's Health and Cancer Rights Act of 1998 is a federal law that provides protections to patients who choose to have breast reconstruction in connection with mastectomy. This law applies generally to both persons covered under group health plans and persons with individual health coverage. The Health Insurance Portability and Accountability Act, or HIPAA, was developed in 1996 and became part of the Social Security Act. It assures health insurance portability by eliminating job lock due to pre-existing medical conditions. It also reduces healthcare fraud and abuse, and it enforces standards for health insurance and guaranteed security and privacy of health information. MAPIA, or Mental Health Parity and Addiction Equity, prohibits group health plans that offer mental health benefits from imposing more restrictive annual or lifetime limits on spending for mental illness than that are imposed on physical illnesses. Patient Protection and Affordable Care Act was enacted to ensure that all Americans have access to quality health care that is affordable, And it also eliminated the pre existing clause that prohibited some consumers from being able to purchase a quality healthcare plan. Lastly, the Federal No Surprises Act, or NSA, was effective for services received after January 1st, 2022. This protects a consumer from surprise bills for emergency services from an out of network provider or facility and without prior authorization, out of network cost sharing, like out of network coinsurance or copayments for all emergency and some non emergency services. It also provides protections of out of network charges and balance bills for supplemental care like radiology or anesthesiology by an out of network provider that work or contract to work in a network facility. Next slide, please. The Federal Affordable Care Act, also called the PPACA, was enacted in March 2010 and was the most significant change to health insurance since the original Medicare was passed and enacted in 1965. It addresses quality of care, the cost of care, accessibility, and gaps in insurance coverage. Some of the benefits, some of the health insurance reforms began in 2010 and some of the reforms did not begin until 2014. Examples of these reforms include prohibiting lifetime dollar limits and annual dollar limits on essential health benefits, required coverage of specific preventative services with no member cost sharing, guarantee issue of a health insurance policy, and prohibiting pre existing condition limitations. The ACA provided for the 2014 implementation of the health insurance exchanges, also called health insurance marketplaces. Also, a federal website that allows consumers to purchase qualified health plans and to determine their eligibility for federal premium tax credits and cost sharing subsidies. The federal government uses the term health insurance marketplace instead of exchange. OCI continues to have regulatory authority over the insurance companies that offer coverage through the ACA. However, we do not have authority over the marketplace themselves since they are a federal entity. Next slide, please. This is an interactive map on our website. Oh, excuse me. No consumer who signs up for coverage can be refused or have coverage limitations such as pre-existing coverage clause on an ACA policy. There are 10 essential health benefits that are minimally required to be covered under the ACA. They are ambulatory patient services, emergency services, hospitalization, pregnancy, maternity, and newborn care, mental health and substance use disorder services, prescription drugs, rehabilitative services, laboratory services, preventive and wellness services in chronic disease management, and pediatric services including oral and vision care. In 2025, the amounts listed there are the most an individual or family will have to pay out of their pocket for covered expenses under an ACA plan. Next slide, please. And now I would like to pass the torch on to Sharon to continue.
Good morning. Under the healthcare law, insurance companies can only account for 5 items when setting premiums, and those are listed on this slide. However, states can limit how much these factors affect those premiums. The ACA provides that comprehensive individual and small group health plans be categorized into one of 4 different metal tiers. The tiers represent the average portion of expected costs a plan will cover for an average population. The percentages the plans will spend, on average, are 60% for bronze, 70% for silver, 80% for gold, and 90% for platinum. There is also a catastrophic health plan through the ACA, available to eligible individuals who are under age 30 and who qualify for a hardship exemption. Bronze plans usually have the lowest monthly premiums but the highest costs when out of pocket when one gets care. This plan is often selected if one usually uses few medical services and wants protection from very high costs if they were to get seriously ill or injured. The platinum metal tier usually has the highest monthly premiums, but the lowest costs when receiving care. Next slide, please. Open enrollment is the period when changes and updates can be made to an ACA plan for the upcoming year. For example, a plan sold or amended during the open enrollment period this year coming up would have an effective date of January 1st, 2025, if completed by December 15th, 2024. Next slide, please. A special enrollment period, or SEP, is a time outside of the yearly open enrollment period when you can sign up for health insurance. A consumer may qualify for a SEP if they had certain life events like losing coverage, moving, getting married, having a baby, or adopting a child. Depending on the SEP type, a consumer may have 60 days before or 60 days following the qualified event to enroll in a plan. Some examples include losing existing health coverage, including job-based individual and student plans, turning 26 and losing coverage through a parent's plan, getting married or divorced, having a baby or adopting a child, death in a family, moving to a different zip code or county, or a student moving to or from the place they attend school. Next slide, please. This is time for our first poll. And the question is, special enrollment periods allow individuals to enroll in the ACA outside of the normal enrollment period when that person, and I'll give the audience time to put in their answer. And the answer here is C, loses eligibility for Medicaid. Next slide, please. The state of Wisconsin continues to offer a highly competitive market for consumers looking at the exchange. We also require an insurer to offer the same plans off exchange in the individual market. There's an interactive map on our website that allows you or a consumer to narrow down the available plans to the county the consumer lives in. It lists what type of plan, like an HMO, POS, the plan is, a contact phone number for that plan, and it will also link you directly to that company's website. Next slide, please. Under the Affordable Care Act, health insurance companies cannot refuse coverage or charge you more just because you have a pre-existing condition. That is, a health problem you had before the date that the new health coverage starts. However, policies not subject to the ACA, such as short-term limited duration or fixed indemnity, may continue to have pre-existing condition limitations. A health insurance company may use different criteria or definitions from what a healthcare provider may use, and obtaining medical records is not the company's way of determining whether a condition was pre-existing or not. Next slide. If a consumer or provider disagrees with an insurer's determination that they have the right to appeal through a grievance, all insurers that issue health benefit plans must develop an internal grievance procedure. Insurers are required to file with the OCI an annual grievance report to show how many grievances they handled during the previous year. The independent review process provides an insured with an opportunity to have medical professionals who have no connection to the health plan to review a dispute. The IRO has the authority to determine whether the treatment should be covered by the health plan. Next slide. The definition of medical necessity is not in Wisconsin law or statute, as it is defined by the insurance company, and the company's opinion of necessity can differ from the provider's opinion. Thus, the reason that the grievance and IRO procedures were developed. Examiners at OCI do not make medical determinations, as we're not medical professionals. For example, some of the most common complaints we see are differing opinions between companies and providers on the number of sessions necessary for physical therapy or for surgical procedures necessary. Next slide. The payment of a claim is not overdue until 30 days after the insurer receives the proof of loss required under the policy or equivalent evidence. Also, a delay in payment may be justified if the insurer cannot determine to whom the claim should be paid to. The date of payment is the date a check or payment was properly mailed, or, if not mailed, the date of delivery of the payment. This does not apply to self-funded, Medicare Advantage, or Medicaid plans, along with those providers that have provider agreements with the company. Next slide. Which of the following is true? A, short-term plans are required to provide coverage for pre-existing conditions. B, qualified health plans under the ACA are required to provide coverage for pre-existing conditions. C, OCI is able to make medical determinations regarding pre-existing conditions. Or D, filing an action in court is the only way to resolve disputes regarding pre-existing conditions. And I'll give the audience a minute. And the answer is B. QHPs under the ACA are required to provide coverage for pre-existing conditions. Next slide. In any state, there can be challenges geographically to ensure that there are adequate number of providers for a plan's number of enrollees. And we have received complaints in the past concerning the number of providers within an area. Wisconsin statute does not define how many providers must be located within a certain mile radius. In a lot of these cases, we ask companies to work with their members to find providers that fit their needs, or we'll work with them to possibly approve seeing someone outside of the network if a provider cannot be found. Next slide, please. All ACA compliant plans must have embedded out-of-pocket maximum. All family deductibles must be no more than double the individual deductible rate under the ACA. For example, if the individual deductible is $3,000, the family deductible can be no more than $6,000. And this measure is an effort to alleviate the financial stress on smaller families. This can be confusing, so make sure to check the policy and ask questions. It is important to understand and explain how and what accumulates towards the deductible and out-of-pocket max. Next slide, please. There are two types of deductibles, but the difference matters only for plans covering more than one individual. The difference has to do with the amount an individual or a family must reach before the insurance company begins paying for expenses. Embedded deductible means one family member can contribute more than the single amount towards the family deductible, and this helps to relieve financial stress on smaller families. In the case of a non-embedded deductible, a family can apply to a member and spouse, member and children, or member, spouse, and children. Next slide, please. For a consumer to fully understand the cost of their health insurance plan, you must start with the premiums and then add in cost sharing. Remember, the amount of out-of-pocket cost may exceed the stated out-of-pocket max if a copayment does not contribute towards meeting the out-of-pocket max. This must be defined in the policy language. For example, a specialist visit copay of $50 may not go towards that out-of-pocket max. It's very important for a consumer to understand this possibility. Next slide, please. This and the next few slides show a sample found on the healthcare.gov website of the summary of benefits a company is to provide to its members. This is a snapshot of a health plan's costs, benefits, covered healthcare services, and other features that are important to consumers. The summary of benefits also explain health plans' unique features, like cost-sharing rules, and include significant limitations and exceptions to coverage, all in easy-to-understand terms. Next slide, please. Next slide, please. And next slide, please. Next slide. Wisconsin insurance mandates apply to all group health plan policies covering hospital care, with an exception for groups less than 10. Mandates begin with Stat Section 632-895 Sub 9, coverage of drugs for treatment of HIV. Those apply to self-insured by a county board, by a city or village, by a local government unit or technical college district, by a town, or by a school district. Some self-insured plans and governmental units use third-party administrators to administer plans and pay claims. Next slide, please. Group health insurance policies and self-funded state and local government health plans must provide coverage for mental disorders, alcoholism, and other diseases. This includes inpatient, outpatient, and transitional treatment for alcoholism, drug abuse, and mental or nervous disorders to ensure that the financial requirements and treatment limitations on mental health or substance use benefits are no more restrictive than those restrictions on medical or surgical benefits. Group health policies are required to provide coverage for transitional mental health, alcohol, and other drug abuse treatment arrangements, such as hospitalization. HMOs, in addition to covering the mental health services described above, are required to provide certain benefits for outpatient treatment of nervous and mental disorders, alcoholism, and other drug abuse to a dependent student who is attending a school of higher education located in the state but outside the HMO service area, if the HMO would have provided benefits for such services by a selected provider within the service area. Next slide. Preventive care services are not subject to cost sharing when delivered by the insured's network. COVID-19 immunizations is a preventive health care service. High deductible plans mean first dollar only available for certain preventive care benefits, such as an annual physical. And you can refer to a list of preventive services on healthcare.gov or the U.S. Preventive Services Task Force. Next slide, please. COBRA is the federal law allowing most employees, spouses, and their dependents who lose their health coverage under an employer's group health plan to continue coverage at their own expense for a period of time. COBRA applies to insured health plans and self-funded employer-sponsored plans in the private sector and those plans sponsored by state and local governments, and applies to employers who have 20 or more employees. Next slide, please. Wisconsin's continuation law applies to most group health insurance policies providing hospital or medical coverage. The law applies to group policies issued to employers of any size. Additionally, employees who live outside of the state of Wisconsin during employment with an employer located within Wisconsin would be eligible for continuation coverage. The law does not apply to employer self-funded health plans or policies covering only specified diseases or accidental injuries. When both laws apply to group coverage, it is the opinion of our office, where the federal and state laws differ, the law that is more favorable to the insured should apply. Next slide, please. Key points are separation from the employer cannot be for gross misconduct, and the individual continuing insurance must pay 100% of the premium. You may be asked, am I eligible for a special enrollment period under the ACA if I decide to drop my continuation coverage or stop paying premiums during the 18-month eligibility period? No, you are not eligible for special enrollment if you voluntarily cancel your continuation coverage before your 18 months of eligibility have been exhausted and you are outside of the annual open enrollment period for health insurance. It is the responsibility of the employer to notify the enrollee of their continuation rights, not the insurance company. Next slide. And finally, here are some OCI resources available for you on our website. Thank you.
All right, so we have time for some questions. If anybody has any questions, please feel free to put them in the live Q&A. We'll give everyone a couple of minutes just to see if anybody has any questions. All right, looks like Brandis has a question. Brandis, I will give you some time to type that in. Looks like there's a question if you are able to explain a little more about cost sharing.
I could take this on, and let me know if you want any more specifics about any type of cost sharing. But essentially, cost sharing refers to the expenses that the insured has to pay. So a policy can be structured any number of ways, but some typical types of cost sharing are copays, and that's an amount that you pay at the time of a service to receive that service. They're typically amounts between $10 and $50, with higher copays for kind of more involved services. There's coinsurance, which is the amount, when we were talking about those different metal levels, that's coinsurance. The amount that the insurer pays, say 60%, and then the amount that the insured pays, the 40%, is the insured's coinsurance. We also have deductibles, which are the amount that the insured has to pay before the insurance kicks in. Am I forgetting any? Well, those are three types of cost sharing, the three main ones. I think those are all of them. Did that answer your question?
Awesome, thank you. Brandis is wondering if a person gets a new job and has a child who has a pre-existing condition, when does her coverage start?
Okay. Give me 1 second here.
Of course.
Oh, are we recording these questions?
Yes.
Okay, then I will stop writing it down. I'm going to get back to you on that question. Because
Okay.
whenever we get into like real specifics, and this is Sharon speaking, I'm the health insurance attorney. I just want to make sure I'm dotting my I's and crossing my T's.
Absolutely.
So I'm assuming that we will be able to get contact information.
Yes. Yep. Yeah.
Okay,
we will get all the questions over to you guys, and then we will share them out after the conference. The answers. We'll share the answers out after the conference.
And I see definitions of the terms. Judy, could we, I know we kind of had a lot of terms. Are there some in particular that you wanted me to discuss, or otherwise we could connect one-on-one?
There's a question from Nona as well about.
Okay. Is there a way to break down and explain some of the plan information? Let me see where we would be going in our slides for that. I guess I'm not entirely Do you know, could you provide me a little more context for what information you're looking for, Nona? Oh, there were a lot of terms throughout. I wonder if it might be helpful, just because I'm not, okay, hold on one second. I'm wondering if perhaps it would be helpful. I see that Judy and Nona's question are kind of similar, asking for a lot of the terms and explaining some of the plan information. Maybe I could provide a summary addressing those kind of questions, and that'll allow me to kind of go through the slides and try to figure out what might be responsive to what you're asking. So I could kind of prepare something for everyone.
Great. Thank you, Sharon.
What are we missing here? Would someone mind, because it's kind of, I'm not sure if I'm getting all the questions, if someone maybe could just read the next question.
When the plan slide popped up, they need more explanation from that slide.
And I'm just trying to, there were just so many slides, so I'm trying to figure out which we might have been.
And Sharon, if I could interject just for a
sure.
moment. Judy, to answer your question, what I would advise you to do is go to our website, which is oci.wi.gov. And within that website, you will find what we call a glossary of terms. So that, I think, will give you some definitions of some of the terms that we use today. At least I hope it encompasses a lot of them. But that is probably the best source to find some definitions.
And I don't know if anyone can chime in, but I'm wondering, or Nona, do you know the specific slide? I just can't remember where we said it's pretty self-explanatory, or maybe around what part of the presentation. Was it when we were going through are you talking about like when we were going through the summary of benefits?
That was the slide I was thinking of as well.
Sure.
Yes.
Yeah.
Okay. So, awesome. We can get that slide back up on the main stage here in just 1 second.
So I'm wondering, it's a little hard in this format to do a real question and answer. But I believe first that our contact information is shared. Is that correct? Like my contact information?
I think we have the base, like the main OCI information out to everyone.
Well, I'll just put out there, people are welcome to contact me with questions. I do have a lot of, cases and other things, but if you have some quick questions, I'm happy to answer. But I'll try to go through what might be some of the terms that people are wondering about on these pages. So we kind of discussed a deductible. And sometimes there are separate deductibles. You'll kind of see that for prescription drug coverage. And that's just like a separate category. You have to meet your $300 drug deductible before your insurer will pay for your prescription drugs. So we have an out-of-pocket limit, and that kind of depends on whether you're going in network or out of network. And then there's a couple things that are not included in the out-of-pocket limit. So when you're talking about an amount that you have to pay, and that's like your maximum cost sharing, it's not going to include premiums, for example, because premiums aren't really cost sharing. That's like the cost to get coverage in the first place. So there's certain things that just aren't included in the out-of-pocket limit. Could we go to the second slide? And so this is kind of like a schedule, and this is just going to vary depending on the type of insurance you have. But these are just kind of the general categories of like services and then what you would pay in network versus out of network. All of these like schedules, like what we see in these four slides, those all look like very much alike. They're all kind of like the same categories and stuff. And so the information in it, like the ones on healthcare.gov. So the information in it is just going to vary depending on the specific policy. So all of these are ACA compliant, and they're referring to costs associated with different mandated benefits. Could we go to the third slide, please? And here we have exclusions. So, plans can be more or less generous once they've covered those mandated benefits. So here's a sample, and this is pretty typical. Typically dental is you have another dental plan for, it's not included in your major med. Cosmetic surgery will never be covered, things like that. Infertility treatment might be if you have good health insurance. So it really kind of varies. And then it lists your grievance and appeals rights. Minimum essential coverage. It basically means how do I best put it? Essentially, it means that like you would not be subject to a tax penalty, except that we don't have that anymore. I'm not going to get into that. Fourth page is just an example of like how this might all play out. And you can contact me if you have more questions, or I might refer you to a health examiner, but we could also connect. Are there other questions, or I'm seeing what is the list for MEC? I'm not sure what that refers to. Elena, do you know?
Yeah, I'm not sure what MEC. Oh, I wonder if it's
minimum essential coverage, but I'm just not sure what a list means.
Yeah, what the
list of what qualifies. Yeah. It might be on the schedule here. Did we have a slide on that? I'm sorry.
I don't think on minimal essential coverage. I was able to find it on the healthcare.gov website, but it's just a very general screen.
Yeah.
So that was
on page. Oh, excuse me, Kelly.
Yeah,
I'm sorry.
No, go ahead, please.
I think what we're getting at the slide, on this some types of things.
Which
MEC
slide number was
includes,
that, Sharon?
health insurance the one we're on right now, or is it?
Oh, okay.
Yeah.
Okay.
Minimal essential coverage.
Okay.
And this is very general, but the marketplace, individual market policies, Medicare, Medicaid. It's really anything you can think of as either ACA regulated major med or major med provided by like, Medicare, Medicaid, TRICARE. And then there's some other types that could come under that heading.
And again, these slides were found originally on the healthcare.gov website. So that would probably be a pretty good outlet for anyone that has further questions on it, then to click on those links as well.
Perfect. All right, so it looks like we are winding down to the end of our session. Just to remind everyone that login information will be sent again for pre-licensing tomorrow morning. And then the next week's sessions will be sent out by email as well, starting tomorrow. Tomorrow we start at 8:30 a.m. We have 2 presentations again from OCI and 1 from Covering Wisconsin. And we will see you bright and early in the morning. Thank you so much for joining us.